Good afternoon, my name is Gustavo Rey. I'm a third-year resident at Orlando Health, and today I'll be presenting my project titled End-Tidal CO2 predicts early mortality better than shock index in trauma patients presenting to a level 1 trauma center. So let's first talk about End-Tidal CO2. End-tidal carbon dioxide is the maximum partial pressure of carbon dioxide at the end of exhalation. End-tidal CO2 has been shown to correlate with lactate and other markers of metabolic acidosis. Its utility allows for real-time assessment of critically ill, unstable patients, and it's a safe, non-invasive study that can be used continuously with minimal cost. Shock index, on the contrary, utilizes a mathematical equation that consists of heart rate over systolic blood pressure, and it has become a well-established marker for identifying critically ill patients in the emergency department setting. The degree of shock correlates with an increasing shock index value, and a score greater than 0.9 is associated with higher mortality. The objectives of our study was to compare end-tidal CO2 to shock index in predicting early mortality and injury severity in a large cohort of trauma patients. This was a cross-sectional study evaluating end-tidal CO2 and shock index from a level 1 trauma center registry, and this was conducted over a 2-year period from July 2016 to August 2018. The primary outcome measures was early mortality, and that's prior to hospital admission, and the secondary outcome measures was injury severity score. Injury severity score is a standardized scoring system for severity of traumatic injury based on worst injury of 6 body systems. This type of scoring system is primarily used in the research setting with a particular emphasis in trauma literature. Our data was analyzed using Spearman correlation and area under the ROC curve with 95% confidence in predicting early mortality. So we had a total of 1,596 trauma patients registered to our study. The mean age was 39 years old, and we had 1,157, so 73% of our study population being male predominant. We had a total of 1,353 that were admitted to our hospital, and I think that was about 85%, with 44% of these patients going directly to the ICU, and a small proportion, 2.4%, that did not survive to hospital admission. Now, taking a closer look at non-survivors versus survivors. So our mean injury severity score overall in the study was 14, and that kind of falls within the range of mild to moderate. The mean injury severity score in non-survivors was 33, and in survivors was 13, and that was with a p-value of less than 0.001. The mean shock index value in non-survivors was 1.06, and the mean shock index value among survivors was 0.81. And that was with a p-value of 0.094. With end-tidal CO2, our mean end-tidal CO2 level was 20 in non-survivors compared to 31 in survivors, and that was with a p-value of less than 0.001. In Figure 1, you see the ROC curve for predicting early mortality after trauma. However, before jumping into our data findings, I would like to just quickly review the receiver-operator characteristic curve. The ROC curve is a fundamental tool that allows for diagnostic test evaluation. In the ROC curve, you essentially have true positive rates, so sensitivity plotted in function of false positive rates, so 1 minus specificity, for different cutoff points of a parameter. Each point of the ROC curve represents a sensitivity and specificity pair corresponding to a particular decision threshold. The area under the ROC curve is a measure of how well a parameter can be distinguished between two diagnostic groups. A test with perfect discrimination, no overlap between the two distributions, has a ROC curve that passes along the left upper hand corner, and that in itself represents 100% sensitivity and 100% specificity. Therefore, the closer the ROC curve is to the upper left hand corner, the higher the overall accuracy of the test. And in general, an area under the curve with a value of 0.5 suggests no discrimination, whereas a score of 0.7 to 0.8 is considered acceptable. 0.8 to 0.9 considered excellent, and anything greater than 0.9 is considered outstanding. So if you look at our chart on the left, you see that we have 3 different curves, each one representing initial end-tidal CO2, initial shock index, and injury severity score calculated. And as you can see, the area under the curve is highest with your initial end-tidal CO2 value, which had a score of 0.77. In Figure 2 is a scatter plot showing an inverse correlation between end-tidal CO2 and injury severity score. So what it shows, as the initial End-Tidal CO2 value increases, you have a decrease in the injury severity score. And in the contrary, as your initial End-Tidal CO2 value decreases, you have an increase in injury severity score. In figure 3 is another scatter plot that shows a positive correlation between shock index and injury severity score. So what you have is, as your initial shock index value increases, you have an increase in injury severity score. And in the contrary, as your initial shock index value decreases, you have a decrease in injury severity score. So in conclusion, End-Tidal CO2 and shock index correlated with injury severity. End-Tidal CO2 predicted early mortality in trauma patients better than shock index. And given that End-Tidal CO2 is a quick and non-invasive study, it has the potential to be used as a screening tool at triage for predicting mortality without having to calculate the shock index. So some future considerations. We're currently working on a prospective study comparing End-Tidal CO2 and shock index in predicting mortality and injury severity. We would also like to evaluate End-Tidal CO2 in different patient subsets, with an emphasis on excluding severe isolated head injury patients, as they tend to have higher mortality rates without your typical physiological changes that would be expected with other forms of trauma.